Arthroscopic lavage has been advocated for the treatment of septic arthritis of the hip, but uncertainty exists regarding the optimal number of portals, the amount of fluid used for irrigation, the use of continuous suction irrigation systems, and the use of postoperative drains. In this study, the results of arthroscopic drainage and debridement high-volume lavage using a three-portal arthroscopic technique by bird in the supine position with no postoperative drains for the treatment of septic arthritis of the hip are described. Between 2001 and 2008, 12 patients with primary septic arthritis of the hip underwent arthroscopic debridement and drainage. Now, regarding the technique, the patient is positioned supine on a fracture table. A well-padded perineal post is positioned between the legs for counter traction. Both lower limbs are abducted approximately 25 degrees, positioned in extension and neutral rotation, and anchored to foot placed. A fluoroscopic C-arm is positioned between the legs. Three standard portals are utilized. The anterior portal coinciding with the intersection of a vertical line drawn distally from the anterior superior iliac spine and a transverse line drawn medially from the superior margin of the greater trochanter. The anterolateral portal located over the anterosuperior margin of the greater trochanter, and the posterolateral portal which is located over the posterior superior margin of the greater trochanter. The anterolateral portal, which is located more centrally in the safe zone, is established first using a 15 centimeter 17 gauge spinal needle under fluoroscopic control. Capsular penetration is confirmed by backflow of pus or synovial fluid, which is collected for culture and microscopy. Traction is applied to both lower limbs simultaneously to prevent the pelvis from tilting or shifting. And joint penetration is confirmed again by what we call contrast aerogram, which is created by the negative intracapsular pressure created by joint destruction. The joint is destructed approximately 10 to 12 millimeters. A stab wound is made through the skin over the entry point of the needle, and a switching wire is passed through the needle. The needle is removed, and a cannulated obturator with a 5 millimeter arthroscopy cannula is passed over the wire into the joint. Once this portal is established at 70 degrees, arthroscope is inserted for initial joint orientation. The other two portals are established using the 15 centimeter 17 gauge needle under direct arthroscopic visualization and fluoroscopy. Once they are established, a 5 millimeter cannula is passed over the switching wire into the joint to allow interchangeability of the instruments and arthroscope and allow a high volume of fluid flow. Synovial samples are taken, and limited synovectomy is performed with an arthroscopic chondrotome. The joint is irrigated with 6 to 8 liters of physiologic saline. We did not use continuous postoperative intra-articular irrigation or postoperative drains. Hip range of motion was allowed immediately after surgery, as well as weight bearing. Intravenous antibiotics were started empirically with flucloxacillin and ceftriaxone, and were later readjusted according to the culture results. Although the patients were able to be discharged after 5 to 7 days, intravenous antibiotics were continued as an outpatient using an elastomeric continuous infusion device and a PEEK catheter for 3 weeks. Then oral antibiotics were given for another minimum of 3 weeks. The patients were followed weekly to fortnightly with the clinical examination, leukocyte count, CSR, and CRP levels. All patients presented with a short history of painful limitation of motion of the affected hip. At presentation, all had an elevated temperature, leukocyte count, CSR, and CRP levels. The synovial cultures yield Staphylococcus aureus in 9 patients, Staphylococcus aureus in 1, and Staphylococcus pyogenes in 1. In 1 patient, no organism was identified, but this patient received antibiotics prior to presentation. The patients were followed for 6 to 74 months. At the last review, the highest hip score ranged between 96 and 100 points. All patients had a full range of motion of the hip, and there were no complications. There's inconsistency regarding the number of portals used. We believe that 3 portals will offer better visualization and instrumentation and allowing a more thorough debridement. Regarding the amount of fluid used for irrigation, some autos used up to 25 liters of physiologic saline. We think that smaller volumes are sufficient, reducing the risk of fluid leakage causing compartment syndrome and reducing the risk of fluid overload. We did not require postoperative drains, eliminating the risk of drain entrapment. The same, we didn't use any suction irrigation systems, eliminating the risk of secondary contamination and infection with the new bacteria. In conclusion, we think the 3 portals arthroscopic surgery and a large volume irrigation is an excellent alternative to open arthrotomy in the evaluation and treatment of septic arthritis of the hip. It offers a less invasive approach, joint preservation, and diminished mobility. Thank you.
Thank you very much.